Good day, everybody. It was really interesting to hear both the talks just now. And if one thing became clear, I think it's time to move away from the one-size-fits-all approach. Yeah, if it's plausible in any given situation. And you see, ultrasound is one way to do that. Now, I brought to you a couple of ultrasound loops that I've recorded during cardiac arrests. And I'd just be really interested in you telling me if you think that patient has a pulse. Let's have a look at this one, at this heart. Who thinks this patient could have a pulse? Raise your hands. Okay, not so much, yeah? What about this patient? Could he have a pulse? What do you guys think? Okay, overwhelming majority. Well, let's continue. What about this patient? Pulse? Ooh, 50%. So as you can tell, it seems that CPR and resuscitation and pulselessness, it's not a binary thing, right? It's a spectrum. You're either healthy or we're doing CPR on you, but in between there's something we call shock. And CPR is just profound shock. Now it gets really interesting if you put a probe on those patients, because you can see what's actually going on. You know, doing CPR, that's like doing a nice Formula 1 pit stop. You have a good crew. The crew knows what to do. Everybody has their positions. Then the patient comes in and you perform your maneuvers. And as you get into, I've never been in a Formula 1 pit stop before, but I imagine it looks something like this, their workbench. Maybe it's a little bit more modern. You can see up there, there's a duct tape. That's our adrenaline. You know, it kind of holds things together, but it just fixes some parts and prolongs the time for everything to fall apart anyway. So what we can do, if we want to have a modern mechanics shop for our CPR pit stops, we can integrate the diagnostics machine, right? Because every good car mechanic nowadays, they have a diagnostics machine that they plug into the patient, into the car, and it tells them what's going on. So I think of ultrasound as that diagnostics machine. Now, what can we do with our ultrasound during CPR? When we consider diagnostics, there's mainly three things. Okay, we can do echo during CPR. We can look at reversible causes, which both of them integrate into one another, because you can see a lot of reversible causes when you're doing echo. And then thirdly, you can also do a pulse check with point-of-care ultrasound. We're in the YEM-TRACK session, so I'm sure you guys are a little bit familiar with the current literature. What do you think, how good is our manual pulse check if we palpate it? Just shout it out. 50%. Yeah, 50% roughly. Yeah, so you might as well just flip a coin. That's where POCUS pulse check came from, that we can actually use ultrasound to do a pulse check. Now, we have our CPR going on with the... Are you feeling all right, sir? Oh, I think we have a problem. Team, please, can you get... Oh my God, what's happening? Uh-oh. I think we have a cardiac arrest case.
Put on the monitor, I take care of every management. Put on the pedals. Pedals on. We're doing pre-charging. Yes. All right. Pedals are on.
We have to do ultrasound, right? I was just at the EUSEM conference and they told us we have to do ultrasound during cardiac arrest. Ultrasound to the rescue. Sorry guys, I just have to do some...
What the fuck are you doing?
I forgot to switch it on. One second.
Would you like me to continue?
No, I almost got it.
The patient is gonna die.
Yeah. We heard that from Tobias already. Patients are gonna die.
You have nothing else to do?
Just a
Just
few more.
shock the patient.
Yeah,
or
okay.
Do something else.
Yeah, the heart is not beating.
Yeah. Congratulations.
All right, thanks to the team. Big applause. Ultrasound is cool, but, big but. What's to follow is a symbolic picture of me 5 years ago being a medical student, really interested in ultrasound. And I would ask my consultant if I could do a little bit of ultrasound during cardiac arrest in our resus room. And I remember getting into the room with the ultrasound machine. I was a fresh med student, right? And the team looked at me, and I looked something like this. So nobody knew who I was. Nobody knew what I was doing there. I didn't know what I was doing, to be honest. I've put the probe in people before, but not during a resus, and I had maybe 10 times looked at a heart before. So what happens if you put this guy into this high-performance team? I don't think the pit stop is going to be as successful, right? And that's essentially what you see if you look into the studies, and that's essentially what the guidelines are trying to tell us. Thank you for pointing that out to us already. Ultrasound prolongs pulse checks, rhythm checks, yeah, same thing. But is it the ultrasound actually, or might it be the people? Because the ultrasound machine, it's stupid, you know, it just stands there. It doesn't do anything. I thought about photoshopping like a mean, angry ultrasound machine, but I didn't have the time. So just imagine it in your head. People prolong rhythm checks. So it's really important for us not to just say, hey, let's do an ultrasound on this CPR patient. We have to integrate it into our system. We have to integrate it into our processes. Now here's the time to take a picture. This is your checklist for doing ultrasound during CPR. You're familiar with the step-up mnemonic? So S stands for self. You've got to check yourself first. Do I want to do the ultrasound because I'm an ultrasound enthusiast? Or does the patient need it? Does the patient profit from it? T for team. Is there enough ultrasound expertise available and enough team resources? If I'm the team leader of a cardiac arrest and I'm the only one who can do the ultrasound, I probably shouldn't do it, because during the time that I'm busy with the ultrasound machine, fiddling around, preparing everything, recording the loops, interpreting it, there's a lack of team leading, yeah? There's a vacuum going on, and that might lead to your resus going sideways. So either you have a very flexible construct, maybe you do a nurse-led code at your hospitals. So if you're the only one who's experienced in ultrasound, you should set someone else as the team leader during that time or during the whole resus. E for environment. Is there enough space in the room? Is the ultrasound machine available? And the P for patient. Maybe there's another more important procedure, and ultrasound, you know, having the big machine around, it's going to take attention away from that important procedure that's actually going to help the patient. Yeah, traumatic cardiac arrest, do some bilateral thoracostomies, stuff like that. There can be things that are more important at the moment. Now, looking back at our workshop, we've got those 3 things that we can do for diagnostics, right? And I want it to be a practical talk, so now we're just going to look at some videos. Echo during CPR. How do we do it? We use the echo probe, and then I've looked at all the studies, but essentially there's a very few different options where to put the probe, right? So I asked a personal favorite of mine, Bruce Lee, what he thinks. And Bruce Lee, well, he always punches subxiphoid, right, into the solar plexus. No, I'm a little bit kidding, but actually not. So subxiphoid position seems to be the best position for you to do it during CPR. And Bruce Lee also has another nice quote. What does this mean if we translate it to our CPR ultrasound game? I think we should, if we start out with it, we should stick to one position only so that we get really good at it, at the subxiphoid view. It's going to tell us a lot, and in most patients it's very feasible to get. Now, yeah, ultrasound Bruce Lee. Next slide that you can take a picture of, that's the practical how to do echo during CPR slide. So you have 2 main things. First, you got to brief the team beforehand so that they know that the dog picture, that he's coming in and he's doing ultrasound. You've got to assign the POCUS role. And it's essential that you assign that role to a person who's not otherwise involved. And you've got to limit the rhythm check to 8 or, well, 10 seconds max. If you limit it to 8 seconds, you're always going to be under the 10 seconds, so I like to do that. And it's really important to count it out loud. And as soon as the countdown is over, you just, if the ultrasound person doesn't go away, you have to, you know, like punch him or something. Just get him away from the patient. Because what's essential is the basics. And it's essential that we keep the rhythm check down and below 10 seconds. Then you're going to get a view during ongoing compression. So you're going to put the probe on at least 10 seconds before the rhythm check starts. You're going to record a loop. You're just going to keep hitting the loop button on your ultrasound machine. Also important that you know where that is. And then you're not going to interpret it at all. You're going to take the ultrasound machine after the 8 seconds. You're going to go away into your corner. And then you're going to interpret the images. Yeah, and if you have another doctor with you or a paramedic, one who's knowledgeable about ultrasound, you can do a 4-eye view of that loop, and then you interpret it together and you share what you found with the team. What does it look like in practice? This is ongoing CPR, right? Yeah. So I recorded that loop. Did I do a good job? What do you think? You're all nodding? I don't think so. You see, in the beginning, I still have to adjust the depth. Yeah? Right here. And now I'm like, oh, I can't see very well. And now I still have to adjust the depth. That's not a proper way to do it. You put the probe on the patient before so that you know what is my depth, what is my gain, what are the settings I need, so that you don't have to touch any knobs while you record the loop. That's essential. Now, if we look at our patient selection, what are the patients that profit the most from ultrasound? Well, it's our PEA patients, the patients who come in pulseless electrical activity. And through recent studies, we know that those are the most interesting patients because they have a lot of different reversible causes going on. And I want to share some patient stories with you now. So this is a 70-year-old female, PAA, unwitnessed out-of-hospital cardiac arrest, coming into your resus room. You brief the team, you got everything ready. You've got one person who's doing the ultrasound, puts the probe on, you know, during ongoing compressions. And this is the rhythm check. What does this heart look like to you? You know, the team leader asks you now, do we have cardiac activity? Look really closely. Who says there's cardiac activity? Put your arms up. All right, about half the room. Very nice. I'll get to that later. Now let's look at the next patient who comes into the resus room next to us. She's a 45-year-old patient, also PEA, witnessed out-of-hospital cardiac arrest. You put the probe on during the rhythm check, and you see this here. That was an actual case. We did CPR, and then we saw this picture. Is there cardiac activity? What do you think? Ah, now it's the whole room. This pearl is really important. If you ever do echo during CPR, it's important to distinguish PEA from pseudo-PEA. Do we have cardiac activity? Yes or no? PEA, press, you can see it up top. It's called pulseless with a rhythm. So we see a rhythm, potentially perfusing rhythm on ECG with echocardiographic standstill, no cardiac activity. Or we have PREM, echocardiographic motion. If you look at the studies, it seems to be an okay prognostic factor. The RUSC rates, they differ, 10% versus 70%. Neurological outcome and so on, that's something else. But it seems that the prognostic factor is really important, and also the differentiation that we're going to get to now. Because the definition of cardiac activity is that you have organized ventricular activity with a change in diameter of the LV. Now think back to that first loop that you saw. Was it cardiac activity? That wasn't cardiac activity. And that's what happens a lot in practice, that people see a little bit of movement of the valves and say, hey, there's cardiac activity, but it's not. Okay? And it's a huge difference if you think about reversible causes, if you think about where the patient is going to go next. So we can use ultrasound to uncover pseudo-PDA, to uncover patients that may profit from other interventions, may profit not so much from chest compressions, but more catecholamines, for example. So if we take a look at this video, that's another patient right here. You can see the mitral valve. The mitral valve is at the bottom right there. I do have a pointer. Let's use that. That's the mitral valve fluttering right there. You know, the patient is in PEA, so there might be a little bit of electrical activity going on. But this is clear as day PEA. There's no cardiac activity as it is defined in the studies that, you know, looked at PEA and pseudo-PEA. Now, if you have a patient and you push adrenaline into that patient, it looks like this. Now you can see in the right ventricle, there's some bubbles. You know, that's the adrenaline essentially going into the heart. And you can see the mitral valve is wiggling a little bit faster. But is there organized ventricular myocardial activity with the diameter change of the LV? Still PEA. Another thing to watch out for, this right here. You see blood moving, right? What's happening as I recorded that loop? You're giving breath to the patient. Okay, so it's just ventilation of the patient, changes in intrathoracic pressure, and it passively moves blood into the heart in and out. Okay, also PEA. Now another patient with pseudo-PEA right there. We can see there's a little bit of organized ventricular activity and a diameter change in the LV. I'm going to point that out to you again. This patient is in profound shock. Okay, he's not going to have a great blood pressure. But this is PREM. And another example for pseudo-PEA would be this patient. What's his problem? Tamponade, right? And this leads us to reversible causes, yeah? Because pericardial tamponade, that's one of the factors that you're going to see when you do echo on patients. And the prevalence of pericardial effusion in resus patients is actually 4 to 8%, yeah? It's quite high. And if you see tamponade like that, what do you have to have in the back of your mind? What could it be? Underlying pathology? Yes, dissection, type A dissection. Very nice. So those are the reversible causes. Now, in essence, those 3 things you can do with ultrasound during CPR to help your diagnostics. You can do the echo, reversible causes. You can also do a POCUS pulse check. If you want to know more about these things, just hit me afterwards. But it's essential that the ultrasound game, it doesn't do the patient any good if you can't integrate POCUS into your process of doing CPR. May ultrasound Brûlé be with you.